Good afternoon and welcome to today's presentation, Sleep Disorders. The information presented by the expert is not to be used as legal advice and does not indicate a working relationship with the expert. All materials obtained from this presentation are merely for educational purposes and should not be used in a court of law sans the expert's consent, i.e. a business relationship where she or he is hired for your particular case. In today's webinar, Dr. Grinman will discuss common sleep disorders, symptoms and unusual behaviors of sleep disorders, how to screen and test for sleep disorders, medication and sleep disorders, and legal implications of sleep disorders. To give you a little background about our presenter, Dr. Lev Grinman is the co-founder and medical director of HomeSleep LLC, which is one of the largest providers of ambulatory home sleep testing services nationally. He is a clinical instructor of neurology at Stony Brook University Hospital. Dr. Grinman is board certified in Neurology and Sleep Medicine. Attendees who require passcode, the word for today is sleep. During the Q&A session, we ask that you enter this passcode into the Q&A widget for CLE reporting purposes. The Q&A is located to the left of your screen. Please remember that if you're applying for CLE credit, you must log onto your computer as yourself and stay for the full 60 minutes. You are also required to complete the survey at the end of the program. Please note that CLE credit cannot be given to those watching together on a single computer. Tomorrow morning, we will send out an email with the link to the archive recording of the webinar. The slides can be downloaded from the resource list at the widget at the bottom of your screen. Also, Dr. Grinman has 2 videos in the presentation that you can also view in the resource list as well. Thank you all for attending today, and Lev, the presentation is now turned over to you.
Hi, everybody. My name is Dr. Grinman. You may have seen my presentation 2 days ago on intraoperative monitoring, which is another field of interest to me. If you did, welcome back. Today, I'm going to be talking to you about sleep disorders, and we're going to start by basically listing what types of sleep disorders exist and why they're important. So, this lecture is meant to give you an overview of the common sleep disorders that are seen by a sleep specialist. And I also made some special emphasis on conditions that have been used or presented as part of evidence or as a comorbidity in medical legal cases. The first condition that I'm going to be speaking about is insufficient sleep syndrome. Very simply, most of us do not get enough sleep. An average adult requires about 8 hours of sleep to function optimally during the day. Now, there are people out there who naturally do not need 8 hours. They may need 6 or 7 hours, but that's unusual. What's more is some people are just the opposite. They may need 9 hours of sleep. Or 8.5 hours of sleep, and some people need much more to stay to be at their optimum function. So 8 hours is an average, but that's exactly what most people need. I should also note that children and teenagers need more than 8 hours. So when somebody is in school, when they're a teenager in high school, or when they're even in college, most often those kids will need an additional 1 to 2 hours of sleep. Now, as I said, most people do not get enough sleep for a lot of different reasons. And what's more, besides the fact that we just don't get enough hours of sleep, some of us may have underlying sleep conditions, one of them being sleep apnea, which causes interrupted sleep, multiple awakenings during the night, and will contribute to lack of function during the day. As you may have realized from personal experience, insufficient sleep can lead to poor mood, symptoms of depression, problems concentrating, difficulty with memory, and overall work function. An important concept is something called sleep debt. What that means is that if a person is not sleeping sufficiently for several days in a row, or even if somebody's chronically sleep deprived, but they get 1 or 2 days of make-up sleep, extra sleep, on the weekends, they accumulate something called sleep debt. and that is the many hours of sleep that you just didn't get but needed. And that's important. The concept is important because when somebody gets one night of good sleep, it doesn't mean that they reset their clock. It's just the opposite. Somebody may feel very tired after a good night's sleep, and very often that's due to the fact that they accumulated the sleep debt and have not slept at all. Of course, insufficient sleep is associated with motor vehicle accidents and poor job performance and also injuries on the job. The next disorder I'd like to talk about is insomnia. Insomnia is something that most of us have experienced at some point in our lives. For some people, it's a chronic condition, and there are many things that are sort of present in our lives that can predispose somebody to insomnia. Now, people who have chronic anxiety are more prone to having insomnia, and it can be a vicious circle of not sleeping well, being more anxious, and not sleeping well again. However, there are many things that some of us can do to help with being able to fall asleep quickly at night. A lot of us are guilty of having poor sleep hygiene, and what that means is that we do certain things around bedtime that will be a barrier to being able to fall asleep easily. The next slide is sort of some things that list things that can keep you awake versus things that can help you fall asleep. And in general, things for many of us in the modern day of having cell phones with such as iPhones and also tablets that we take with us into bed, that is one of the biggest culprits. The phones tend to release certain light wave frequencies that can fool the brain into thinking that it's still bright or it's still daytime. We rely on lack of bright light to start making more melatonin, which is a chemical that's normally produced in the brain to help us fall asleep. So when we're looking at our cell phones, for example, our brain doesn't get the signal that it's getting dark out. And actually, my cell phone has a setting called night work, where certain frequencies of light, such as the short frequency blue light, is eliminated, and the screen looks a little bit more dim and more yellow. And because and that's the light that's eliminated, that's the frequency that will stimulate the brain the most. And so every night when the sun goes down, I have it on that mode so I don't, so it doesn't interfere with my sleep. There are certain other things that can contribute, such as consumption of alcohol. Even though alcohol can help somebody fall asleep faster, when alcohol is metabolized by the body, it actually becomes a stimulant and can be and can cause somebody to wake up in the middle of the night or to just have generally restless sleep. The important point here is that for insomnia, most effective therapies are actually cognitive behavioral, not medications. Many people will come to a sleep physician in order to stop taking their medications and not the other way around. And what we typically do with such patients is we teach them how to improve their sleep hygiene and also a couple of other tricks to help them stay calm around bedtime and be able to fall asleep better. It's important to also note that insomnia medications can cause unusual behaviors associated with memory loss and a couple other things. So that's why sleep physicians are typically not fans of sleep meds. Next condition is a very prevalent one, but is also a very underdiagnosed one, and that's obstructive sleep apnea. Some studies have shown that 9 out of 10 people who have sleep apnea are not diagnosed at this time, and that can be worrisome because of the implications that untreated sleep apnea can have on somebody's health and also on the safety of that person or people who are around that person. Very simply, what is obstructive sleep apnea? Basically, when we sleep, we have a collapse or we have a decreased muscle tone in some of the muscles in our body, including the muscles that surround our airways in the neck or in the back of our throat. And as we fall asleep, that decreased muscle tone can predispose somebody to have a collapse of their airways. The tongue may also pull back a little bit. And if somebody's carrying some extra weight on their body, they're also carrying extra weight in their neck, and that added weight can also contribute even more to the collapse of the airways. When we're not breathing during our sleep, it can cause a lot of different issues with our other body systems, such as the heart. It can also cause problems, obviously, with it can also predispose one to having increased risk of strokes, heart attacks, and a host of other things, including diabetes. And, of course, when somebody's not getting sufficiently good sleep during the night, because what happens is a person will stop breathing. They're trying to breathe, but they can't. The air can't get in. Eventually, the brain will realize that something is wrong and will wake the person up, or the person will go into a very light stage of sleep and cause an arousal. And some people can wake up hundreds of times during the night without realizing it. And, of course, that will cause them to be very tired during the day. Classically, sleep apnea is known to be a disease of middle-aged men, but one has to be careful not to generalize. I've seen young people in their 20s who have sleep apnea, and sometimes they're very thin. It has to do with the general anatomy of their airways, and so if somebody presents with symptoms of sleep apnea, I take it seriously, even if they don't look like the typical patient. As we'll discuss a little bit more, obstructive sleep apnea is currently a hot topic in the transportation industry. There's been a couple of accidents in the last few years where the operators of the trains or bus drivers were found to have obstructive sleep apnea, and that was felt to be a contributing risk factor to the crash. And it's also, as I will show you, becoming a fairly common legal defense in certain cases. Whereas previously, people in certain professions that involve heavy machinery or people who fly airplanes would go to lengths not to get tested because they felt that they may be taken off their job, which is really not true. Since sleep apnea is so prevalent now, employers know that this is something that needs to be treated, but the person should not be punished by being taken off their job. And what's more, in the last couple of years, using some of these transportation accidents as an example, people will actually jump in and say, hey, maybe I had sleep apnea and that's why I crashed that train, because that becomes a medical excuse as opposed to a problem with their, as opposed to not being a responsible driver or operator. How is sleep apnea diagnosed? It can be diagnosed in two ways. Classically, patients went to a sleep lab where they were hooked up with a lot of different wires that went on their head, on their chest, on their finger, on their legs, and there were a couple of other sensors that could look for other issues such as leg movements during sleep. In the last 5 to 10 years, there's been a move to test patients in their home. It's a more natural environment. It's a much simpler setup, but it has been shown to be almost as accurate as being in the lab, about 90% as accurate. And so you can do a home sleep study to diagnose somebody with sleep apnea. Once somebody has a diagnosis of sleep apnea, there are a couple of different treatment options. The most common one and the most effective one is positive airway pressure. If it's continuous, it's called CPAP. There are also machines out now that will auto-titrate, meaning they will actually sense when somebody is not breathing when they're using their machine, and they will give them extra air support or pressure support during their sleep. The concept for both devices is very simple. I liken it to a leaf blower in that it basically just increases the pressure in the back of your throat and helps to keep your airway open. Now, it's 100% effective. Unfortunately, not everybody can sleep with a mask on and air blowing into their face. So that's where that's sort of the biggest issue that we come up with when trying to treat patients with sleep apnea is the non-compliance with their therapy. And we're able to accurately measure compliance these days because a lot of the machines have chips that measure the amount of hours that the device is being used, and also it can even tell us if there's any residual apnea when they are using it. Some patients can also get an oral appliance, which is something that is put in by a dentist. It's kind of like a mouth guard, but what it does is it thrusts the lower jaw forward and puts the airway in a more optimal position and thus prevents some of the apneic events. Occasionally, surgery can be done. It's typically done by an ENT specialist. There are a lot of different surgeries out there. Unfortunately, many of them are not very effective. The ones that have been shown to be most effective are those that protrude the lower jaw forward permanently. And so some patients choose to undergo surgery. As I said, the compliance is measured by the device. What I have here is one of the videos that was sent to you, and you'll be able to also watch after the presentation. Unfortunately, I can't play it here, but I'll describe it for you. It basically shows a man, not an old man, but somebody who's probably in their 30s, having sleep apnea. This person is, you could tell by the movement of their chest and their belly that they're trying to breathe, but they're not getting any air in. And it looks like a pause for maybe 20 or 30 seconds, after which he starts gasping for air. And it looks pretty scary, and it can be. At this point, I wanted to see if anybody has any questions.
If all the attendees can enter in the passcode for today, which is sleep, does sleep apnea and snoring go hand in hand?
Yes, absolutely. So snoring is a symptom of sleep apnea. The reason snoring is caused by the turbulent airflow in the back of the throat. So if somebody has a perfectly open airway, you will not have snoring. But once the airway starts closing, the air will not be traveling smoothly, and and the tissues in the back of the throat will start to vibrate. And that vibration is what snoring is. And so almost all patients with sleep apnea complain of very loud snoring. It may not be super loud, but definitely some degree of snoring. And when the airways are completely compressed, that's when we have an apneic episode, and the person is not breathing or not getting sufficient air. And so it's on a spectrum. Once the snoring gets severe enough, the airway closes up, that's when you have apnea.
How can one tell the difference between mild and severe obstructive severe sleep apnea?
Okay, that's a very good question. That is actually, it's an objective measure that we use based on the sleep studies, and I didn't go into the severities of sleep apnea, but I can go a little bit into that now. It's really based most of the time on the number of times per hour of sleep that a person has an episode of either apnea or hypopnea. So an apnea is a complete or 90% occlusion of airflow. Hypopnea is about a 70 or more percent occlusion of airflow, not quite as severe as an apnea, but both events are, especially hypopneas and almost always apneas, are associated with drops in oxygen levels. So if you have a sufficient enough drop in oxygen levels combined with obstruction of the airway, then we call it either an apnea or hypopnea, depending on the severity of the closure. And then what we do is we measure the number of these events per hour, either of sleep, if we know exactly when the patient's sleeping in the sleep lab, or per hour of testing time when a test is done in the home without an EEG. And so if somebody has 5 or more events per hour of sleep, that's considered mild. If you have 15 or more events per hour of sleep, that's moderate, and 30 or more is severe. I've seen patients who have been as high as 120 to 150 an hour. It's pretty crazy. But anytime you have 30 or more events per hour, that's considered severe. There's a couple of other things to consider, and that is mainly the oxygen levels. So it's important. Studies have shown that the lower your oxygen goes during the night, the more likely you are to have secondary health complications of sleep apnea, mainly difficult to treat high blood pressure, irregular heart rhythms such as atrial fibrillation, diabetes, and a couple of other health conditions that can be helped by treating sleep apnea.
Is obstructive sleep apnea potentially deadly?
Absolutely. Obstructive sleep apnea can be deadly in a couple of different ways. You may have seen Carrie Fisher's autopsy results that came out in the news over the last couple of days. She had multi-drug intoxication, it looked like, but they also said sleep apnea may have been a big contributing factor as she was sleeping on the flight home and probably stopped breathing several times. And the reason a person can die in their sleep, the most likely reason is the pressure of if you have enough events and maybe if your oxygen levels go low enough, it starts to affect the function of the heart, and the heart may go into an abnormal rhythm as you're sleeping. And if it's a deadly rhythm that it involves not getting enough blood to your brain or to other parts of your body, then you can actually die from that. Long term, people who have sleep apnea for several years will accumulate or the risk and possibly the health complications that I already spoke about that can predispose them to having these conditions and to potentially dying from these conditions.
If someone has a iPhone attached to them and it shows interrupted sleep, should they be concerned?
It really depends. So we have a lot of great technology now that is able to tell us a lot more than we were aware of previously. The cell phones have actigraphy in them, and that is software that basically can tell movement, and that could be used if it's used during sleep, and it shows that there's significant movement during sleep. That can be associated with restless sleep. You have to realize that most people, almost everybody, does wake up several times during the night for different reasons. We probably just don't remember it, or it's so brief that it doesn't cross our conscious barrier. However, if you do start seeing a significant amount of movement during sleep, and say if you also snore, I would consider maybe seeing a sleep specialist and getting a sleep study done. Again, you should be also very careful not to overgeneralize or use a device such as a cell phone to make a clinical diagnosis. But yes, potentially if you move a lot during your sleep, that could be a sign that there's something else going on.
Thanks, Lev. You can continue with the presentation.
Okay, very good. Okay, so the next topic that I wanted to cover are abnormal behaviors during sleep. And they can include talking in your sleep, walking in the sleep, and sleepwalking and sleep talking are more common in children, but can occur in adults. And sometimes there may be a predisposing factor that causes somebody to do these things. It could sometimes be sleep apnea, rarely, or it's more commonly associated with certain medications, especially medications taken for insomnia. I think the most research has been done on Ambien, and people on Ambien have been shown to have a whole host of things happen to them when they're under the influence of it. Especially in the elderly people already have a more frail disposition. They may have other underlying medical conditions. They may be on multiple medications, and when you add something like Ambien into that mix, it could be potentially dangerous and sometimes deadly. So it's known that Ambien can cause neuropsychiatric reactions such as hallucinations, sensory distortions, and even contribute to delirium, and amnesia is very common. People will not remember that they did something the night before, and will only realize the next morning that they went to the refrigerator and took something out. So people have been documented, walking, eating, and even driving, under the influence of Ambien. It's not clear if they were completely asleep or if they were sort of in a daze, kind of a state where they were, sort of kind of out of it. And people have also been known to engage in sexual behaviors. It actually has a specific term called sexomnia. And again, people will not recall doing these things. And so that's a significant worry for me as a sleep doctor. As I said, the elderly at higher risk for having potentially complications. Why that's important is that when you're older, you're at much higher risk for having hip fractures or other injuries when you fall. And so an elderly person will get out of their bed. They may be confused. They will fall to the floor and break their hip. That's a problem. And as a matter of fact, there have also been reports of even murder cases associated with Ambien use. It has been used as a defense. It doesn't always work, but certainly it's possible that people under the influence of sleep medications can do unusual things, including potentially become violent. The next topic we're going to cover is narcolepsy. Narcolepsy is a very interesting condition. It's fairly rare, but I'm sure most people have heard of it and maybe know somebody with it. It's due to chemically or neurologically, it's due to the absence or an inefficient or ineffective function of a chemical made by the brain called hypocretin, or it's also called orexin. And when you don't have a properly working orexin in your brain, you start having symptoms of narcolepsy. A lot of these symptoms are due to the fact that REM sleep, which is the part of the sleep where we dream and are often paralyzed, actually intrudes into the awake state. And so these patients will often complain of unusual hallucinations around sleep time. Potentially, they might see something as they're falling asleep or getting out of sleep, and that's because the REM sleep is somewhat there, even though they're partially awake. Patients may also complain of something called sleep paralysis, where they're awake, they just woke up, but they can't move, and that can last several minutes, and from what I understand, can be very terrifying. Now, sleep paralysis can also occur in a normal, healthy person, but it's very rare, whereas in people with narcolepsy, it can happen quite frequently. Symptoms of narcolepsy typically begin in late childhood or adolescence. They can sometimes be mistaken for laziness or lack of motivation. You have these kids who are falling asleep in class, acting funny, and so the teacher, and sometimes kids can be even hyperactive, not underactive or hypoactive when they are derived with sleep. And so some patients may not be diagnosed properly for many years. And the reason people are tired during the day when they have narcolepsy is because they typically do not have they have restless sleep. It's not completely understood why, but the sleep tends to be very restless, and that's probably part of the reason why they're tired during the day. What sets them apart from a lot of other people, for example, those who have sleep apnea, is when they take a nap, it actually can be very refreshing to a person with narcolepsy, where somebody who has sleep apnea will say, you know what, I can take multiple naps during the week, but I still feel like crap. Rarely, narcolepsy can occur as a result of head trauma, where certain brain structures are damaged, and that probably causes a misfunction or causes a problem with the production of this chemical hypocretin. There are actually two types of narcolepsy. Recently, they've been called type 1N and type 2N. The only difference between them is something called cataplexy. Cataplexy is a very interesting phenomenon where a person who has narcolepsy, if they get emotionally excited, and this could be in a state of anger, or when they're very happy, say they're about to laugh, when they're hearing a joke, they will actually lose muscle tone in their body and may fall to the floor. It may be a partial paralysis, it may be a full paralysis, and sometimes they will actually go straight into sleep. And it can be very scary and it's one of the most unpleasant experiences, from what I understand, for a patient with narcolepsy, is to have cataplexy because it's embarrassing. And the reason it happens is for some reason REM sleep intrudes into the awake state and causes this paralysis that we normally have during REM and causes the person to fall down. As an aside, the reason we're naturally paralyzed during our sleep is most likely because to prevent us from acting out our dreams, which makes sense because that could be dangerous. Type 2 narcoleptics have no cataplexy, but again, all patients with narcolepsy share many symptoms, including excessive fatigue during the day, that's helped by a nap, occasional paralysis during awakening or falling asleep, and fragmented sleep. Narcolepsy is also not an easy condition to diagnose, meaning there are very objective rules as to how narcolepsy should be diagnosed, but there are a lot of things that have to be done right by the sleep specialist. A person with narcolepsy will typically go into a sleep lab and have a sleep study, and it's a two-part sleep study. They will have an overnight portion where they sleep where they're supposed to sleep for at least 6 hours, and then they will stay the next day and take 5 20-minute naps during the day. And the physician is going to be looking for two things. One, do they fall asleep during their naps? Because a normal person, typically after a normal night's sleep, even in a sleep facility, should really not be falling asleep very quickly, given an opportunity of 20 minutes at a time. Whereas a person with narcolepsy will fall asleep very quickly, typically within 5 minutes. And what's more, on several of these naps, you will see REM sleep. Again, very unusual for a healthy person to go into their dreaming stages of sleep within 20 minutes. Usually it should take at least 60 to 90 minutes. So the diagnostic criteria for narcolepsy should show are that the person falls asleep very quickly, and that they have intrusion and that they have REM sleep during some of these naps. It's important to note, and I've seen this a lot, there are a couple of things that could make the diagnosis invalid. So if somebody's on psychotropic medications, such as antidepressants or mood stabilizers, some of these medications can affect the results of the study, and so patients have to be taken off of them before the study is done, typically for at least a couple of weeks. So if somebody comes into the sleep lab and they're taking, several medications that can affect their brain function, you can't really make a definitive diagnosis of narcolepsy. It's also important to make sure that the person gets enough sleep the night before, and that's because if they're overly tired after their overnight, they're going to be more likely to fall asleep anyway. Also, the reason the overnight study is done is to make sure that there's no other untreated sleep disorder. I've seen patients be diagnosed with narcolepsy where they actually have untreated sleep apnea. It may seem like the person has narcolepsy, they may be falling asleep during the day a lot, but really it's from something else, such as OSA. And if you have an underlying disorder, you have to treat that first before going back and possibly retesting the patient if they still have symptoms. I've seen sleep physicians who've been practicing for many years make the wrong diagnosis. I've seen cases, legal cases or disability cases, where a claimant will say they have narcolepsy, and it was a diagnosis that was given to them by a physician. But upon closer inspection, a lot of these are just unimpressive because the testing was not done correctly. One of the last things I'm going to talk about as far as a general category is REM sleep behavior disorder. This is a rare condition. However, it's an important condition in the medical legal field. There have been a couple of cases where it was used as a defense, and it's also a very striking condition. Basically, as I had said, we are normally paralyzed when we sleep, or especially during REM sleep, we're completely paralyzed. And patients who have REM sleep behavior disorder, they're not paralyzed during REM, and so they can act out their dreams. It's also unfortunate, but a lot of these people tend to have very violent dreams, very unsettling dreams. Many will describe being chased or being punched and kicked during sleep, thinking that they're in combat with somebody. And so what they will then exhibit themselves is violent behavior because they think that they're fighting somebody. And often bed partners can get hurt. Patients have even tied themselves to the bed to prevent injury to their bed partner and themselves. This is another example of a video that I can't show you right now, but you can see on your own. It's a very clear example. It's an older video of an elderly gentleman who's peacefully sleeping, and all of a sudden he sort of sits up in bed, and after a few seconds starts punching the side of the bed as though he's engaged in a fight. And this person was actually completely asleep at that time, so it's pretty scary. One example of a legal case where REM sleep behavior disorder was noted is a case in South Wales where a man strangled his wife in his sleep because he thought he was fighting an intruder, and he was found not guilty based on the fact that he had this REM sleep behavior disorder. It's also interesting for a neurologist to understand that REM sleep behavior disorder is sometimes associated with neurodegenerative conditions such as Parkinson's disease. And it can be a harbinger of Parkinson's disease, meaning somebody can start developing and be diagnosed with REM sleep behavior disorder many years, up to 10 years, before they start having first classic symptoms of Parkinson's disease, which is the rigidity and the tremor that comes with it. And so neurologists are always on the lookout for something else that may be going on with that patient who has been diagnosed with RBD. Patients may respond to benzodiazepine medications such as Klonopin for the management of their symptoms. Unfortunately, it often doesn't completely resolve their symptoms. Okay, the next topic is legal implications of sleep disorders. I wanted to discuss how sleep disorders have been showing up in legal cases. They are showing up more and more from what I've seen. Sleep apnea has been in the news after a few notable train crashes and also bus crashes. For example, the New York MTA has this year instituted a company-wide or an MTA-wide rule that all bus drivers and train operators have to be screened, and then if the screening is suggestive of sleep apnea, they have to be tested for sleep apnea. The company that I helped start, HomeSleep LLC, is actually one of the companies that is working with the New York MTA to test patients and to also help get them treated if a diagnosis is made. And we are in talks with other companies across the country, other rail systems, and manufacturers of trains and buses to help them start the process of maybe testing their employees because, A, that will save them a lot of money. These accidents are very costly. And also improve the health of their employees and, contribute to improve safety. Next couple of slides, I wanted to show you some incidents that have been in the news. New Jersey train engineer in crash had undiagnosed sleep apnea. This was an accident that happened within the last year, I believe, in New Jersey, at a New Jersey train station where the train operator didn't stop the train when he was supposed to stop inside the train station, kept going and caused a lot of structural damage. And it was then found out that he had sleep apnea. Another accident was the Metro North accident, I believe it was in 2013, that resulted in a fatal derailment. This was a sentinel event, actually, for the MTA to start the process of screening their engineers. This was also the first fatal accident involving passenger fatalities in the history of Metro North. Sleep apnea, this was an interesting case that I actually almost got involved in. Just to show you that sleep apnea is being used as a defense, not just in motor vehicle or other types of transportation accidents, but also, and I'm going to quote here, in the case of airplane groping, Kaluza was able to convince the jury that his client suffered from apnea and was so fast asleep on the trip that he mistook the woman's breasts for multiple pillows he usually uses to prop himself up in his bed back home. This was on an airplane, obviously. So the jury apparently didn't care that the defendant also had stayed up all night and downed scotch and Tylenol PM before the flight, and really honed in on this diagnosis of sleep apnea. And he was exonerated, and, very interesting defense. Sleep apnea has also been used as a defense in car accidents. There was a case where, it was a very sad case, where a man drove into a crowd of high school kids and killed two teenage boys. And he was later found not criminally responsible because he had sleep apnea. In this case, they indicated that he stopped breathing 30 times per hour. 30, if you remember during our Q&A a few minutes ago, is the threshold for severe obstructive sleep apnea. There have been also a couple other legal cases related to sleep disorders. There was a very costly, a $20 million reward given to a family of a fairly young man who died during a sleep study. Now, the sleep study took place inside a hospital, inside Emory University, and the staff did not respond quickly enough to his complaints that he had shortness of breath. And so because this was a highly publicized case, and again, the reward was fairly large. In the crash that injured comedian Tracy Morgan, they found that the Walmart truck driver that hit his vehicle had been affected by insufficient sleep, and it's a very common problem in truck drivers. They try to get their haul to where they're going, and often they will forego sleep, take a lot of stimulants, and really be a danger on the road. I have seen instances of sleep apnea-related deaths after surgery, and the reason for that is you may have patients who have not been properly diagnosed, have been diagnosed, and are just not using the therapies such as CPAP. Now they go into surgery. They're given a lot of strong pain medications, specifically opiate pain medications, that will suppress the breathing drive. And when you combine these medications with sleep apnea, it can result in death. And so patients may have gone through surgery, been okay, and then one day later, all of a sudden die in their sleep. And it's very scary. I have also seen cases where sleep apnea was actually used as a wrongful termination defense. A person was terminated from their job, and he said that he should not have been let go because he was diagnosed with sleep apnea while he was still an employee. And so that was an interesting case in that he tried to say that his terrible job performance over the last 5 years was really due to the fact that he had obstructive sleep apnea. And again, there have been many other cases involving sleep disorders. I didn't list all of them, but they're definitely becoming more prevalent, and it's becoming a big public safety issue. Sleep apnea is one of those conditions that has really popped up and has become many people are well aware of what it is as compared to just a few years ago. People travel with their CPAP devices, and so when people get together with their friends, a lot of times you'll hear stories of how somebody's doing with their CPAP, and then somebody else will chime in and say, hey, I have a CPAP too. What pressure are you at? So it's almost humorous that it's become such a common thing now for people to come out and say, hey, I have this condition. At this time, I wanted to see if there were some questions, and I'll be happy to answer them. I'm also happy to perhaps, if we have a couple extra minutes, I can go back and expand a little bit more on some of the topics that I already spoke about.
Oh, we do have some questions, and if you want, you can go back and expand on some more if you like.
Sure. Absolutely.
If I can have all the attendees enter the passcode for today, which is sleep. Our first question, are night sweats something to be concerned about?
They can be. Night sweats is a symptom that, in an otherwise healthy person, night sweats could be indicative of underlying sleep apnea. The reason for that is when you're not breathing, your body can literally go into a fight or flight response, and the person may start sweating. Because you're not breathing, you're choking in your sleep, you may start sweating for that reason. And if people consistently wake up with night sweats and they also snore or are witness to have pauses in their breathing during sleep, that's something that may be addressed, potentially should be addressed by a sleep specialist to make sure that there's no sleep apnea. So yes, it could be something to worry about if it happens a lot.
Next question, why do people twitch in their sleep?
That's a good question. We're not completely paralyzed during most of the sleep cycle. Some of the twitching may be associated with sort of a loss of muscle tone. That is then the body tends to try to compensate by then having that twitch, causing a sudden movement. I don't know if we completely know why all twitches occur, but it's not something to worry about. There's actually something that most people will have is, if you're falling asleep, say you're in a lecture or in a meeting and you're falling asleep, you may jerk. And that's because you start losing muscle tone in your neck and a couple other muscles normally as you're falling into sleep. And so if the brain then, and so once you start losing that tone, the body may and the brain may adjust and actually cause an increase in muscle tone. And so you have this jerking movement, and that's perfectly normal.
Next question, is apnea only addressed with CPAP or other medical intervention? Also, are there any other ways to reduce its severity or eliminate it, i.e. weight loss, for example?
Yes, that's a very good question. So in a person who's overweight and has sleep apnea, the most important thing they can do, so I already talked about the different therapies, medical therapies that can be used for sleep apnea. But it is very important, and we always talk to our patients about weight loss, especially if they are overweight. Of course, if they're skinny and they have sleep apnea, they're kind of out of luck. But as I was saying, carrying around extra weight also means that you're carrying extra weight in your neck, and that can predispose you to having compression of your airways as you sleep. So weight loss can be very beneficial. And, for example, I've seen patients who are morbidly obese, have severe sleep apnea, then undergo bariatric surgery and lose a lot of weight, and then have no sleep apnea. However, it's important to note that weight loss will help, but it doesn't always cure sleep apnea. What's more, as we get older, sleep apnea can get worse. It just has to do with the fact that as we get older, our airways become a little bit, even the muscle tone becomes even a little bit more floppy, and we just tend to have more sleep apnea. And so somebody who loses weight when they're 30 may stop snoring, but as they get up in age and then they're 40 and 50, the snoring may return even if their weight stays stable. So that's something to keep in mind. And as I was saying, as far as therapies are concerned, the main one is CPAP or AutoPAP, which is the mask that you wear on your face. Oral appliance therapy, mandibular advancement devices can be used. There's a couple of different surgeries that can help. There are a couple of different devices that are on the market now that are inserted by usually an ENT doctor that sort of stimulate the nerves in the back of your throat and help to keep your muscle tone at increase the tone of your muscles in the back of your throat, and can potentially help some patients not have these apneic episodes. But for most people, all these things are only partially effective, and CPAP is really the only thing that guarantees that you're not going to have any events.
Next question, is melatonin effective or beneficial in promoting REM sleep?
It's a good question. Melatonin there's two issues with supplemental melatonin, meaning melatonin that you take over the counter. Number one, a lot of things that you buy that are supplements are really not well controlled by the FDA or any other organizations that keep track of purity of products that are being put out. So the guidelines are not the same for food versus supplements. And so you can have a lot of stuff mixed in there. There could be a lot of filler. There could be even other active substances in something that you think is just melatonin. And so the most important problem that you may have with supplements such as melatonin is that the dosing from one pill to another, simply because there may be a different amount of filler or there may not be any melatonin in there at all. So that's the risk that you take by buying something over the counter. What's more is that even if you do get the right amount of melatonin, there's actually very little literature to suggest that it works to help somebody fall asleep at a regular time. I'm not aware of melatonin contributing to REM sleep. Melatonin basically helps the body and tells the brain to start falling asleep and staying asleep. It's not necessarily associated with REM sleep, but as I was saying, supplemental melatonin doesn't help all that much. There is some literature showing that in patients who are jet lagged, melatonin may be somewhat effective, but even there, it's a little bit controversial.
Can obstructive sleep apnea lead to a permanent heart defect?
I'm sorry, what kind of heart defects?
A permanent heart defect.
So obstructive sleep apnea can cause problems with the heart. It typically, there's different issues. When I think of a defect in the heart, I'm thinking, a lot of times when I hear that term, I may be thinking of somebody who's born with a hole in their heart or something else that was genetic. However, there are other defects, obviously, that can cause heart problems. So the heart may become overly muscular, may become hypertrophied, which affects its ability to function well, and that can be a function of of having high blood pressure and having to push against a high pressure in the body. And sleep apnea can contribute to that. The long-standing episodes of loss of or lack of oxygen can contribute to certain stress chemicals that will tell the heart to start, becoming bigger. And also the lack of oxygen can contribute to heart disease itself, where the vessels that supply the blood to the heart may become more clogged because there's probably an inflammatory reaction that takes place when there's continuous and prolonged lack of oxygen going to the heart. So from that perspective, you could have permanent changes in your heart that are secondary to sleep apnea.
Next question. So just to confirm, all with sleep apnea snore, but not all who snore have sleep apnea?
That is correct. Not everybody that snores has sleep apnea. You can snore but not stop breathing, or even if you do stop breathing, as I had mentioned, there's a threshold for when you can consider somebody having sleep apnea, and that is the number 5. If you have 5 or more events of poor breathing per hour of sleep, then you can say somebody has sleep apnea. If they have 2 or 3 events, again, they're having some events, but it's not significant enough to be called to be given the diagnosis. And also, just because you snore doesn't mean that you're necessarily going to stop breathing. And people often notice that after they drink alcohol, they may snore more. The reason for that is alcohol tends to relax the airways. And so after a night of drinking, somebody will snore a lot more and may also have a lot more apneic episodes. But again, just to answer your question, Just because you snore doesn't mean you have sleep apnea. And I would say 99% of people who have sleep apnea snore. However, there are a couple of exceptions. People who have had upper airway surgery to treat sleep apnea may actually not snore very loudly and still have apneic events. And what I've also seen is in the elderly, especially thin elderly people, may stop breathing. Their airways are just not very strong, and they may have apneic episodes, but don't necessarily have very strong snoring.
Next question. What is the best treatment for early wake insomnia? Generally better sleep hygiene or exercise?
Early wake insomnia, meaning you, did I hear that right? Meaning waking up too early?
I believe so.
That's what you said, early wake insomnia. So it could mean a couple of different things. So there could be an underlying the reason why you're waking up and then not able to fall asleep. It could be obstructive sleep apnea. Since you mentioned exercise has been shown to be beneficial for sleep. There's actually research that shows that if you exercise about 4 to 6 hours before you go to sleep, there is a change in body temperature. When you first exercise, your body temperature goes up, and then it starts to drop again. And we are naturally more prone to fall asleep when our body temperature is dropping. So if you optimize the time of when you exercise, 4 to 6 hours later, your body temperature starts to drop more quickly, and that can actually help you fall asleep better. As far as sleep hygiene, unfortunately, sleep hygiene probably is not as helpful for early awakenings, waking up before you meant to. However, if you wake up and then you start using your telephone or you start doing other things or laying in bed for too long, that can contribute to that insomnia. And by staying in bed for too long, what I mean is if you can't fall asleep after 10 to 15 minutes, the best thing to do is to get out of bed and go walk around, maybe go read. Because if you keep staying in bed when you can't fall asleep, you're going to start associating the bed as the place where you don't sleep, and that makes the insomnia worse.
Next question. If melatonin is ineffective for inducing sleep, what routines or methods do you suggest for inducing sleep?
What I recommend for inducing sleep, I don't typically recommend any medication. I don't recommend supplements. The other issue with melatonin that I may not have mentioned is the brain probably makes a lot more melatonin than you could take as a supplement and have it effectively be absorbed into your body. So what I recommend is exercise, having a light meal at night, or don't have a very heavy meal close to going to bed. Don't drink alcohol close to bedtime. Improve your sleep hygiene by not having your phone or your tablet in bed with you. Don't work too late because you may not be able to, and that's hard to say for people who are professionals and are probably working all the time. But if you're not able to wind down, it's going to be hard for you to fall asleep if you lay down right after you've been working. And a lot of times, a lot of us using computers for work, and so it's a double whammy where we're still sort of hardwired to we can't calm down, and we've had this bright light staring at us for right before we go to sleep.
This one is a two-part question. What is a reasonable amount of time that you should fall asleep, and is there a problem if you fall asleep too quickly?
The reasonable amount of time for most people is it should be less than a half hour. I would say probably within 20 minutes is normal. If you fall asleep too quickly, that could be a sign of being overly tired. So if you're falling asleep at inappropriate times, or even if you're falling asleep too quickly as you get into bed, for some people that could be a sign that they're just sleep deprived. They're just they have insufficient sleep. Or, again, I keep bringing up sleep apnea, but people with sleep apnea will often tell me, Doc, I have no problems falling asleep. I'll even have a cup of coffee before I go to bed. and I'll fall asleep in 2 seconds. And that to me is a red flag because a person shouldn't normally fall asleep after drinking coffee. And that's another thing that people can do is not drink caffeinated beverages in the second half of the day unless they really have to, because that can keep them up. And so as I was answering your question, sometimes in some people falling asleep too quickly can be a sign of a sleep disorder as well.
Thanks so much, Dr. Grinman. We're actually good on time, so I thank you so much for presenting the presentation today. In addition to being your In addition to being your best source for testifying and consulting experts for the past 60 years, TASA also offers e-discovery and forensic solutions, free interactive webinars, day-in-the-life videos, research reports on expert witnesses, including the Challenge History Report 2.0, Professional Sanction Search, and Expert Profile 360. I want to take this opportunity to thank everyone for attending, and most especially Dr. Lev Grinman for his time and effort in creating this presentation. If you would like to speak with Lev, or if you would like to speak with a TASA representative regarding a case you are currently working on, please contact TASA at 1-800-523-2319. One of my colleagues will be following up with you regarding your feedback on today's presentation. This concludes our program for today.